Hello everyone, the meeting will start. Hello everyone, the meeting will start in about 30 minutes from now, so please stay tuned. And as you know, everyone who will attend the meeting today will receive the soft copy of my books on robotic neurosurgery. So please don't forget to leave your email in the chat box by the end of the session. And also I will share the link for you to download your attendance certificate. So thank you so much for joining us today. Hello, everybody. Hope everyone is doing great. Hello, everybody. I believe everyone is doing great today. Thank you very much for joining us. We will be starting in about 26 minutes from now. I believe you can see me and hear me now. Okay, so thank you very much for joining us today. It's amazing to have you all gathered here together, for another webinar. And as you can see, that today we lost a legend of neurosurgery, the father of micro neurosurgery, Professor Ghazi Yashargil, who left us today for his heavenly abode. He has left a void that cannot be filled. It's a sad news for us today. So obviously most of you have seen him, met him, known him, and obviously he's everywhere in our OR, in our practice, in our approaches, in our surgery, in instruments, everything that has been very much influenced. Neurosurgery would never be the same without his contribution. So whatever it is, there's a lot of contribution, a huge contribution of Professor Yashar Gill. So it's a sad day for the neurosurgical community. So we are going to give him a tribute today at the end of the session. And also, I will take up all your questions at the end of the session. So please feel free to send your questions in the chat box and also in the Q&A box if you like. And at the end of the session, I will also allow you to raise your hand so that we can allow you to turn your camera on if you want to talk to the speaker and have some sort of discussion if you'd like to. So also, as I have promised, I will be giving out the PDF copy of my book to every attendee who is going to attend the program live today. So please share your email address in the Zoom chat box, and I will email you directly the link to download the PDF copy of the book. And also, like always, the webinars have a attendance certificate which can be downloaded, which is rather emailed to you once you submit, that's the form. I haven't made a quiz this time. I've been a little bit busy lately. That's why some of my webinars now do not have a quiz, but I will be restarting it shortly once I have a little more time. It's been a little chaotic for me lately. It's a little bit exhausting. I'm in job and everything that comes. So I'll be doing the MCQ things later. Also, it's in my mind, inshallah. But currently, I'm just giving out the certificates. I will send the link to download your attendance certificate at the end of the session in the Zoom chat box. Thank you, Dr. Yusuf. I will consider it by the end of the session when they will all here so that I can just copy and paste and send you soft copies. Okay, thank you very, very much for sharing it. And also I will be sharing the link to download your certificate at the end of the session. The only thing that you need is to submit that form just to receive your email address, just to receive your attendance certificate through email. That's emailed directly to you, and it's a simple procedure. So thank you very much. No, thank you very much, Dr. Yusuf, for joining today. Can you all please share where are you from in the chat box so we can see how many people and from how many places are watching us right now? So I believe that we can just wait till 23 minutes. Dr. Mirza will be joining us shortly, inshallah. So we will start the webinar from there. So please stay in the chat. I'm also Oh, that's amazing. From Jordan. Wow, welcome, Dr. Meher. Dr. Yusuf, yes. Where are you from? Dr. Pirzad, hello and welcome to the program. I hope you are doing great. You are having some amazing annual event in July, I know. That's great, Dr. Yusuf. Eid Mubarak, Dr. Ahmed Fawad Mizad. Eid Mubarak to you and your family. It's an honor to have you here, and I'm wishing you all the best for your upcoming seminar in July. And I'll be happy if you would like to share about it at the end of the session. I will be turning on all the videos so that feel free to share more about it. I think the last date of submission of the Afghanistan Society of Neurosurgery's annual event is 15 June. If correct me if I'm wrong. If anyone is interested in sending, I will rather be happy to promote you to send your abstracts to for the first international annual conference of the Afghanistan Society of Neurological Surgeons. They are promoting the young neurosurgeon especially. So if you have some good paper, please feel free to email them, and I will share the announcement again in my group. Dr. Ahmed Fuad Mirza is a medical colleague from Afghanistan. So please do send your work and get cited. Especially the young neurosurgeons, the trainees. They should take part in these activities. It's very, very important for the career development, especially in the early stages. So I highly promote it. So let's just wait for 20 minutes, and inshallah, Dr. Mirza will be joining us shortly. So please stay in the chat room, in the Zoom room, and we will be starting shortly. So thank you again for joining us. Mm. Hello, everyone, and welcome to the webinar. It's an honor to have you all again with us today. So, just a moment. I'm just sharing the link. So, we will be starting shortly once Dr. Mirza join us, inshallah, in about 18 minutes from now. So thank you very much for joining us today. Please share where are you from in the chat box, and I will be very happy to see you all from where you are watching us. And also, I want to tell you that kindly use the chat box to leave your questions and comments, which will be discussed by the end of the session. And I will also turn on your videos if you like. Okay, so you can just turn on your video. I will send the I will permit everyone to turn their videos on at the end of the session, so you can actually interact with the speaker directly at the end of the session during the discussion session. And also, as I have promised, I will be sending you the soft copy of my book, and the link again, please send your email address in the chat box. By the end of the session, I will copy paste your email address and will send everyone the soft copy of my books on robotic neurosurgery, inshallah. And also, this by the end of the session, kindly send me the email because sometimes it gets overlapped. Thank you very much. Yeah, thank you so much. You can, if you like, you can private email me, like in the private DMs. Okay, just if you want to feel more comfortable. So okay, so and obviously there will be a attendance certificate. I will send the link for you to to download. Basically, I will send you a link. You just have to go and write your name and submit the form, and the attendance certificate will be emailed directly to you on your inbox. So by the end of the session, I will share the link in the Zoom chat box. So stay tuned for that as well. So it's great to have you all today, but as you know, we have lost Professor Ghazi Yassergil today, and it's a huge loss for the neurosurgical community. He had a lot of contribution. Obviously, he changed the way we now operate in neurosurgery. He revolutionized the field, and we see him all the time in one way or another in our practice, in our surgical techniques, in our instruments and everything that's there. Neurosurgery will never be the same, but obviously his legacy will continue. So again, it's an honor to have you all here today. So if there is any specific topic that you wish me to organize a webinar on, please feel free to send it to me. You can email me, you can write it in chat box in Zoom, or you can, message me anywhere on social media, and I will be happy to organize webinar on that topic. As you know, I'm also chairing the education committee of the AANS CNS, joint section for tumors. And under that section, we organize free CME accredited webinars very frequently. So I hope that you are also following the tumorsection.org website. Please follow the tumor section, that AANS CNS joint section for tumors, because we organize webinars on a large variety of topics which are very important, and all of them are free and CME accredited, which is a huge thing because CME accreditation is a very big achievement for all of us. So whenever you attend it live on Zoom, you will be able to download the CME credits by ACME, the American College of CME, the Continuing Medical Education. So please follow that as well. So if you have any question or comments, please feel free to use the Zoom chat box to leave your comments, and please share where are you from in the Zoom chat box. Thank you very much, everyone, for sharing your email address. But can you please send me by the end of the session so that I don't miss any of your email addresses. Sometimes it gets a little bit chaotic in the Zoom box. It's a little smaller box, and there are more questions in the box later on that might, have your messages squeezed in. So it will be great if you just send me after at the end of the session. I will be able to, to take up all of the email addresses and do not miss anything. So again, thank you very, very much for joining us today. And if you have joined just now, I want to tell you that every attendee will receive a soft copy of my book on robotic neurosurgery, and everyone who will attend live. And also, this webinar has a certificate which can be obtained by filling a form. With the link to the form I will be sharing at the end of the session in the Zoom chat box. And you have to do is to submit that. The form, and the certificate will be emailed directly to you in your uh, inbox. So again, it's a very simple process, and everyone gets an automated email, and the certificate is directly emailed to you. So please tell me, where are you from? Please write me your country in the chat box. It will be amazing to see from where our viewers are, and it's so good to have you all here with us. And by the end of the session, during the discussion session, I will be happy to ask you to turn on your cameras if you have any question, or you want to say anything to the speaker, and it will be a great opportunity. A little bit of interactive session, which will be really nice. And as you know. All of the activities are usually recorded and are available on my YouTube channel, and you can see them, review them. I think it's a very, very important and interesting lecture for everyone. It's a little bit of revolutionary. So you are going to, I hope, enjoy it and learn a lot from it. And I think that I'm trying to introduce as many new topics as possible. But if there is anything which is in your mind and you want me to arrange a webinar on, please feel free to tell me. And please feel free to email me, message me, whatever you like, however you like. But tell me if there is any topic you wish me to arrange a program on, and I will be so happy to search for the best possible speaker so that we can have another good webinar on it and have a good talk on it. So as you see, we will be starting like in about 11 minutes from now. So please feel free to send your questions in the chat box, and also share where are you from. At the end of the session, I will send you the link to download your certificate of attendance, and also the link to download the soft copy of my book on robotic neurosurgery. That's great, Dr. Alejandro. It's great to have you. Welcome from Venezuela. And okay, Peru, both of the countries are amazing. I know several of my colleagues from Peru and from Venezuela. I think Dr. Adrian Gutierrez is also, no, I think he's from Costa Rica. But I do have friends from Venezuela and Peru. It's a great honor to have you here. Instituto de Enfermedades Neoplásicas. Okay, that's amazing. New Plastica Center. Oh, that's amazing. I can see that. I hope that you also follow my work for the ANS joint section for tumors. There's a lot going on in the section, and we have just introduced. It's an honor for us to have introduced free CME accredited webinars. You can claim on at least one CME per webinar. They are totally free to attend, and all the top neurosurgeons and who are and trusted, who are specialized in neurosurgical oncology, give out lectures in our webinar series from the ANS transaction for tumors. So those activities are sponsored by the American Association of Neurological Surgeons. I'm a chair of their education committee and running the website as well. So please feel free to attend those as well, especially if you are uh, interested in neurosurgical oncology. So tumorsection.org is the website to go. We have a very active, you know, um, social media there also, so you can just go and see them. I think we will be starting from 8 minutes from now. If you got any questions, please feel free to send them. And also, please use the chat box to share your questions and your comments for regarding the lecture so that we can discuss them by the end of the session. It will be amazing to have an interactive discussion like always, which gives, a lot of clarity. And, we are bringing everyone together from all over the world. It's amazing to have all the colleagues on a single platform. We are learning together. It's an amazing thing. Hello, everyone who has just joined. Welcome to the webinar. We will be starting in about 7 minutes from now, and I'm so happy to see you all here. So, welcome everyone. Please share. Yes, exactly, Dr. Alejandro. We are okay. I see you're a team of 4 neurosurgeons. That's amazing. So, I hope that you have some good exposure there, and you are doing some wonderful work for the people in Peru. So, what surgeries do you usually do yourself? So it will be nice to see if which subspecialty is your focus of interest. So that's amazing. I believe that I also wish to start another webinar series, especially for the neurosurgeon of the working in countries like mine and in countries like ours, the low middle income countries. So we have got some different experience, and I believe that there should be a webinar, a separate series on that as well. So please stay tuned. Dr. Alejandro, I have your email address too, so we can collaborate on some of the programs later, which I have that in my mind. I've been a little busy lately because of I've been in New York. I just returned after my fellowship. So it's a new beginning here in Pakistan as well. So it's a little bit of busy here. So okay, so everyone who has just joined, welcome everyone. And it's an honor and a pleasure to welcome you all here. So happy to see you all. It's amazing to learn together. And as you know, you will all receive the PDF of my book on robotic neurosurgery. Every attendee who will attend the program live will receive the PDF copy of my book. And please share your email address by the end of the session in the Zoom chat box, and I will email you the link to download the soft copy of my book on robotic neurosurgery. It is available in 5 different. Um, oh, really? That's amazing. You have a partner of Pakistan and UCIU of our center. Oh, that's amazing. So who is the partner? I will be happy to know, because it's an honor to have someone from my country as collaborator with you. So again, thank you very much. Okay, so everyone who has just joined, welcome to the webinar. And as you know, every live attendee will receive the PDF copy of my book on robotic neurosurgery. So at the end of the session, please share your email address in the Zoom chat box, and I will share you the link to download my book on robotic neurosurgery. I hope that you will like it, and it will be informative. It's something very futuristic. So for us, it's an interesting topic, and I hope that you will like it too. So, also, as you know, that all our webinars have an attendance certificate. I will be sharing the link with you. All you have to do is to click on the link, write your email address and your name, which you will like to appear on the certificate, and the certificate of attendance will be emailed directly to you in your inbox. It's an easy process, so you can just to make sure that everyone gets an attendance certificate. So if you have any questions, please feel free to use the chat box. And by the end of the session, I will permit everyone to turn their videos on if they like to interact or discuss anything which they wish to discuss with the speaker. Because we have to have a discussion session by the end of the webinar. So again, please share where are you all from, and it's so good to have you here and to welcome you here. Hello and welcome everyone. It's an honor to welcome you all. It's amazing to see you all here. So thank you everyone for joining us today. As you all know that this webinar, I will send you all the free soft copy of my book on robotic neurosurgery. The book on robotic neurosurgery is available in 5 different international languages. So if you have any language preference, please feel free to tell me in which language do you wish me to send you my book, because it is available in Spanish, German, obviously English, and Italian and French at least. So I can send to you in your preferred language. So again, this webinar has an attendance certificate that you can easily receive by filling a form. I will send you the link to the form at the end of the session. All you have to do is to fill the form, and you will be able to receive your attendance certificate directly in your inbox. It's an easy process, and you will be. Dr. Mirza is here, I guess. Hi, Dr. Mirza.
Hello,
Can you hear
everyone.
me?
Yes, I can. Hi.
Hi, how are you?
Good, good. I hope you're fine and everybody is well. Good evening.
Yes, thank you very much. Yes, we are all doing great. We've been waiting for you. It's an honor to invite you and to welcome you today. We were also excited and we were discussing the topic that you are going to discuss with us today. So thank you very much for joining us. So would you like to check your slides before we start the webinar, or
I'm ready.
you are ready? Okay, thank you. I've just hit the recording button. So I believe we can start with, it's a little sad day today for us in the neurosurgical community, because we have lost a legend. Professor Razi Yashargul has left us for his heavenly abode today morning. It was a very sad event for all of us. So it's with deep sorrow that I have to eulogize Professor Razi Yashargul today. His passing marks the end of an extraordinary chapter in the history of neurosurgery, one that redefined what was possible in our field. Widely regarded as the father of microneurosurgery, Professor Yashar Gill didn't just advance our discipline, he rather revolutionized it. He turned once inoperable into operable, and in doing so, he shaped neurosurgery in what it is today. So, though he is no longer with us, his presence lives on in every corner of the operating room and every technique that we use today. And, I think everything that we have in our OR will keep us reminding of him. He's a part of us for sure, and he has changed the lives of many of the patients and all the patients that we will be dealing in the future, because if you can just go through the history of neurosurgery, you will be able to find how much he has done. So though I also want to take a moment to appreciate his remarkable wife, Ms. Deanne Joshua Gill, and actually I had the honor of having been in touch to Professor Joshua Gill through her, and she was, she has also a lot of contribution of her own in this field in supporting Professor Joshua Gill. So when I can fondly remember sending him a copy of my book on basic neurosurgical approaches, which I wrote with Professor Luis Borba a year ago, and I sent him that book, and I happily requested him to write something for the neurosurgeon so that we can actually remember him and keep a memory with us for to treasure and to celebrate maybe and to motivate the young neurosurgeon. So he wrote me a wish, and I included it in my book, which is I shared him on social media today. So we are going to we are going to miss him, but he will be here with us. His memories will echo in everything that we do today. So it's a sad day for sure, but obviously everyone has to go. So it's a sad day, but obviously. So, Dr. Mirza, I won't keep you holding up for a longer period. I'm sorry, but let me introduce you, Dr. Mirza Pojskic. Um, he's basically a distinguished Bosnian German neurosurgeon based at the prestigious University Hospital Marburg, which is a part of the esteemed Philips University Marburg. He's widely regarded as a visionary in the field with a strong focus on augmented reality and robotic assisted neurosurgery. remarkably. He's one of the pioneers of the microscope-based augmented reality, and it's a concept that is now reshaping the way we approach neurosurgical precision. Dr. Pojskic holds multiple leadership roles, as you most of us know about his contributions, and he has written, authored a number of highly impact, and I would dare say quite groundbreaking papers. Many of us have the honor of reading those and going through those, especially if you are interested in more of innovation. So, thank you very much. It's a true honor to welcome you today, Dr. Mirza. It's a pleasure to have you with us today to share your wonderful work and a really, a pioneering work. So, thank you very much for spending your time from your busy schedule.
Thank you, Noor, very much for these kind words and for the kind invitation. It's my honor to be here with you.
Um, Dr. Mirza, I guess I have given you, I have made the co-host so you can actually share your screen and you have all the controls of the host. So you can just use it as you like. If you want to proceed with the visual presentation, please feel free. The podium is all yours now.
Thank you. Okay. Can everybody see my screen?
Yes, we can. Yes, we
Okay,
can.
great. Okay, so good evening, everyone. My name is Mirza. I'm a neurosurgeon currently employed at Philipps University in Marburg in Germany. I was born and raised in Bosnia, and since 2013, I work in Marburg. As Noor said, we have a very sad day tomorrow. The father of the modern neurosurgery, Professor Yaşargil, passed away today. I had a pleasure of meeting him. This is in 2013 with a colleague, Dr. Zahirovic from Bosnia, at the International Basic Neurosurgical course in Antalya in Turkey. I was a scholarship recipient of the Turkish Neurosurgical Society, and this is where I had the chance to meet the legend, the best neurosurgeon and man of the century, of the 20th century, father of modern neurosurgery, and he will be missed. And we all live upon the rules he set, and his legacy will live forever. And later on, I'm going to talk about importance of having solid mentors and teachers in neurosurgery, and we cannot imagine to build a career without it, without having a mentor and without having a role model. So this is my credentials. I am Privatdozent or assistant professor at the Department of Neurosurgery at Philipps University Marburg in Germany. Marburg is one of the oldest Protestant university in the world and one of the oldest universities in Germany and in Europe. It is a university city located some 100 km north of Frankfurt, and our university hospital has the entire spectrum of treatment and care for all diseases and for all conditions. And as I previously said, I was born and raised in Bosnia-Herzegovina, and I've transferred to Germany, emigrated in 2013, and since then I live and work in Germany, but I'm still very much in contact with Bosnia. So we have two subjects today to talk about. One is microscope-based augmented reality, and the second subject is robotics in neurosurgery. I'm going to start with robotics, and then I'm going to go to a second presentation, which is on augmented reality. And before we start that, I just wanted to touch upon on principles of neuronavigation and intraoperative imaging, because that is the first thing we need to understand and talk about when we talk as well as microscope-based augmented reality and about robotics. So intraoperative magnetic resonance imaging, it's a field of intraoperative imaging which started in the 1990s. It was a big game changer in neurosurgery. And my boss and head of department, Professor Nimsky, is one of the pioneers of intraoperative imaging, one of the pioneers of augmented reality in our field. And I'm very honored and lucky to have such a mentor and to learn from him in all of these years. And in the 1990s, so the first intraoperative MRI in Europe was in Erlangen in Germany, and the high field strength MR imager was successfully adapted for intraoperative use with the integrated neuronavigation system. It provided valuable information that allowed intraoperative modification of the surgical strategy. However, its very high cost for establishing a high field MRI in parallel with the distinct progress of the CT technology, computer tomography, as well as increasing demand and interest in the community in a spinal intraoperative imaging has led to a renaissance of intraoperative CT. And besides standard commercial CT scanners placed on tracks like in sliding gantry concepts, movable CT scanners like the O-arm and the Aero CT have developed in the last years. So when we talk about navigation, we first I have to explain shortly the registration of navigation. There are two ways of registration of a patient, whether it be a cranial or a spinal case. One is registration with fiducials. These are these rubber markers which you see on the upper right side of the screen. And standard fiducial or landmark-based patient registration is user-dependent and error-prone. So in a fiducial landmark-based patient registration, you place pre-operatively or in prior to surgical planning these fiducials on the head of the patient, and then you perform a CT. And then during the registration process, you mark the fiducials, and in that way, which are then seen by the pointer and the navigation camera, and in that way you register the patient. Well, in intraoperative imaging, there is a possibility for user-independent patient registration, and automatic registration can be provided with intraoperative imaging with MRI or with CT. And registration accuracy would be the main factor influencing an overall navigation accuracy. In our department, we have an intraoperative CT scanner, 32 slice movable CT scanner, ALO from BrainLab, which is integrated in navigation setup, which consists of a double monitor, either ceiling mounted or on the wall, combination with the dual display system, which allows visualization of co-registered images. So in this photo, we see the navigation camera on the right upper part of the screen, and this navigation camera is practically registering registration points on the CT, the registration points of the reference array, which is attached either to a Mayfield clamp or to a spinal process in spinal cases. And in that way, when we perform an intraoperative image, the software is capable of reconstructing a three-dimensional photo or three-dimensional image of the patient as he or she is during the surgery, and that enables navigation throughout the entire case. So this would be the setting. This is the navigation camera, which registers the points from the intraoperative CT and from the reference array, which is attached on the carbon Mayfield clamp. And this is once more where we see the carbon Mayfield clamp. So these four cubes on the reference array are actually the reference points for the navigation, and this enables you to make an image during the surgery to fuse this image with the preoperative imaging, and in that way you have now the image which is transferred to your operative microscope and which enables you to perform microscope-based augmented reality and to perform a navigated surgery. So after we perform the scan, we do the skin disinfection, draping, preoperative navigation plan is registered with the initial registration CT scan, elastically and rigidly, and there is a spyglass feature which enables you to check the fusion accuracy. So this is how it looks, the fusion of preoperative imaging and intraoperative imaging. This concept is very important to understand because the entire talks on robotics and on microscope-based augmented reality are based actually on a navigation. So once you understand the concept of registration of the patient, either for the cranial or the spinal case, and the concept of navigation, then all of these other concepts are pretty easy to understand. So if you want to register or calibrate the microscope, and to put your navigation plan and your surgical plan into the microscope, then there is a possibility to place a reference array also on the microscope and to co-register or calibrate with your preoperative, intraoperative image and with your navigation plan. So when we talk about robotics, robots are actually everywhere, from the toys until the high industry. This is the first robot of my life, which I got as a kid in 1991 from my father as a gift from one of his many business trips to Germany. And this robot was a big deal back then because it had a remote controller which allowed you to um, go to control the robot and to control its movements. So this is the early 90s, and you would think that some 30, 35 years afterwards, we would have a lot of good robots which we can use in the medicine and industry. And while this is the true for industry, in medicine, until years 2022 and 2023, the development was not that good as you would expect. But due to the explosion of artificial intelligence, machine learning, deep learning in the last 2 years, we are now finally going where we want to go when it comes to robotics in medicine and in neurosurgery. So this is an android woman from Las Vegas. I had the pleasure of being invited to the Spine Summit in Las Vegas in February 2024, and we've visited this high-tech fair where you can lead a conversation with the android. Each of these androids costs $400,000, and this specific android, is able to hold a conversation with the human over 2 hours and really responds intelligently to every question. Is also capable of asking you questions, and it is actually a high tech, or the latest cry of the technique. And this is actually the next step, the giant leap where we are heading with the development of the artificial intelligence. And this could be a step in having surgical robots or androids as assistants in OR. This is a very small step, but this is probably the way where the medicine is going to head. But of course, in very small part of the world, in very small part of the well-developed world, and in some parts of far east. But this is the development which we are going to witness in 21st century. So very current subjects: Elon Musk's Neuralink brain chip. Um, as on one side you have this very cool brain chip from Neuralink, which you put in the human brain and which is supposed to allow you to communicate, one of the many applications, to communicate with the other person only using your mind, so without talking, so only with a mind control. There is also many applications of it for people with amyotrophic lateral sclerosis and for the patients with paralysis. But on the other hand, as in every industry, as in every part of the life, we have recent news of the same company being busted cheating in the latest humanoid robot demonstrations. So when we talk about technology in neurosurgery and technology in medicine in general, there are many cards which are being played not only by the doctors, but also by the producers of the instruments and big high-tech companies. We have now a rise of robotics and of artificial intelligence applications, notably from China. Also, Chinese robot Astrobot S1, very good news for many people around the world, which performs household tasks. Also, on the recent tech fair and science fair, there is also this robot, a humanoid robot, which is capable of almost preparing a breakfast, which is also very good news for a lot of us. But this is now everything being on a stage 0 or stage 1 is still not did not find big application into the medicine. So when we talk about robotics in neurosurgery, we have several applications, and we have stereotactic neurosurgery, epilepsy surgery, deep brain stimulation, spine, cerebrovascular. Um, we have neuroendoscopy, neuro-oncology, peripheral nerve surgery, and future advances. So I'm going to talk briefly about every of these aspects. So, robots between imagination and reality. When we talk about robotics, we imagine actually on the right side R2D2 and C3PO. We imagine androids which can almost feel and talk and which you can um, have a conversation which can help you in everyday life. But actually, the most advanced robot now is the robot on the left side, and this is Mars Rover 1. And this is actually merely a car which is has an automated pilot and drives around Mars and takes samples which are then being taken to the Earth. So not as advanced as we think, especially not as advanced in the practical application. So definition, a surgical robot is any reprogrammable powered artificial sensing manipulator with artificial sensing that can assist in a variety of surgical tasks. The first application of robotic-assisted surgery was in the neurosurgical field and used for brain biopsies in 1980s. This robot was named Puma 200. Delicate neurovascular structures and narrow corridors limit the expansion of robotic surgery in neurosurgery. And when you look at this graph, first published clinical use in humans, you have 1988 Puma, 1994 Minerva, and then a rise in the early 2000s. So this is how Puma looked in 1988. It was used only for brain biopsies, but the principle in which this robot was working is actually the same as robotic arms are today. So we have passive robots, which only serve as a tool which is holding a device once directed to the desired position. We have semi-active devices which perform the operation under direct human control, for example, in compliant mode. We have active devices which are under computer control and automatically perform certain interventions. Systems that are able to perform fully automated procedures, CT-based biopsies or cutting, are called autonomous or supervisory controlled, where a human supervisor will always be close to the robot but does not intervene. If robot is entirely remote control and the surgeon is in charge of every single motion of the robot, we may call it a teleoperated system. So this is the example of supervisory controlled robotic system where surgeon plans the surgery, downloads the surgical plan to the robot, and the robot executes the downloaded plan while surgeon observes the surgical robot operation. We had the robotic telesurgical system, where surgeon controls the robot in real time through the haptic interface, and the robot faithfully replicates the surgeon's motions with the interface. One good example for this would be the Da Vinci robot, which is not very much in use in neurosurgery. And we have the shared control system, the most common robots which are in use, where robot and surgeon remain jointly in control. Surgeon remains in control of the procedure while the robot provides steady hand manipulation of the instrument. When we talk about robot surgery, it is actually a cobot surgery. Limiting factor, it's not the lack of creativity, vision, desire, or capitalization, but it's the inherent complexity of most neurosurgical operations. So cobot surgery would mean that robots assist with a distinct but critical and sometimes difficult task of the surgery. Anatomical localization, stabilization of the hand during prolonged microsurgical work, targeting of the pedicle screws. But in the future, we would expect that it may be necessary for not just one, but several robots to assist in completing a routine procedure such as craniotomy or lumbar spinal fusion. So design of robots, we have mechanical effectors. Rigid tools are most common in spine and endoscopic surgery, and curved tools, for example, in transnasal approaches, biopsies, endoscopic craniotomies to minimize invasiveness and reduce recovery time. And it's important to find a compromise between balance, size, and strength, and the stress the tool is under. Triangulation, movement, overcrowding of the workspace are all technical issues in design and we're working with robots. And one big question is improvement of human-robot interface, haptic feedback, force sensing, strain gauges, and optical force measurements, proprioception feedback with transfer of our proprioception to robotic arm, kinematics, motion amplification and filtering, visualization with CT, MRI, endoscopy integration, augmented reality, and training with program virtual reality and preoperative preparation used to rehearse the surgery. So this is a chat GPT visualization of myself in our operative room. And I've put this image because the rapid development of AI, of ChatGPT, DeepSeek, Perplexity, and all other um, big language models and all other AI companies now leads to a very rapid development of robotics and of augmented reality and of all the gadgets which we use in OR. So when you ask ChatGPT, DeepSeek, Perplexity, or all of these language models, please give me a summation of influence of artificial intelligence on robotics and on augmented reality neurosurgery, you get a pretty straightforward and a very correct answer. So what does AI give us? Enhanced precision automation, AI-powered robotic systems such as the Da Vinci or ROSA or Circ now integrate real-time data processing, allow for more tumor resection, more precise tumor resection, electrode placement or pedicle screw placement, electrode placement, deep brain stimulation, adaptive learning with machine learning algorithms which analyze past surgical data to optimize robotic trajectories, reducing human error, and real-time decision support. AI models such as neural networks, which process intraoperative imaging to adjust robotic instruments dynamically and improving safety in delicate brain and spine regions. For microscope-based augmented reality, AI-enhanced visualization enables that the modern microscopes overlay three-dimensional tumor margins, blood vessels, and critical neural structures in real time using AI-segmented imaging. You have deep learning for image fusion, where AI merges preoperative MRI and CT scans with live microscopic views, which helps surgeon navigate complex anatomy without shifting focus. Going to talk about it a bit later. And predictive AR guidance, AI models which predicts tissue deformation during surgery, updating AR overlays to account for brain shifts in real time. And the key synergies would be in intraoperative data integration, faster and safer surgeries, and remote and collaborative surgery. And the notable breakthroughs, according to ChatGPT and to DeepSeek, which wrote these answers, are the generative AI, GPT-4, diffusion models, which assist in simulating surgical scenarios for training, federated learning, which allows hospitals to train AI models without sharing sensitive patient data, and autonomous robotic systems. Now, some systems now perform routine tasks as such as suturing and drilling under surgeon supervision. Now, this is all not being very lived in the normal clinical practice, in everyday practice at the clinic, just at several very specialized centers, but this is coming, and this will be in 5 to 10 to 15 years. I'm not very sure when, but I think this is going to become a standard, at least in the developed world. So I will talk about first robotics in spine surgery. Current use is, well, not only, but mostly for assisted pedicle screw placement, AI placement of K-wires. Why is it important? Screw misplacement occurs up to 8.7% of the time, leads to clinically relevant symptoms up to one-fifth of the time and one-fifth of the cases. First robot, which was FDA approved for spine surgeries, was Mazor, Spine Assist Renaissance in 2004. Now, 20 years later, there are many, many robotic systems on the market, and the rise of the robotic systems which are produced in the Far East, in the tiger countries of Japan, South Korea, and China, are like in any other technology, actually for the end users positive because it changes the paradigm and it leads to cheaper and more available technology. Also, the robotic arm, which I am using, Circ from Brainweb, is also cost effective because these systems were very, very expensive at the beginning and they are now getting increasingly cheaper and at the same time increasingly better for the end user, which is actually a very good development for neurosurgery. Um, this is the Gertspine-Robin scale on the right side. This is a scale which is used to deem the position of the pedicle screw. Now, when do we use pedicle screws? We use it for stabilization of the spine in cases of instability. For example, in cases of fracture, of oncological cases, tumors, spinal metastasis, infections, spondylodiscitis for degenerative diseases. And there are five classes of screws. There is an A screw, which is a perfect screw, which goes through the pedicle, and there are B and C screws, which have a certain breach of the pedicle medially or laterally. And there are D and E screws, which usually need a revision because there is a breach of the pedicle to the medial or to the lateral side more than either less or more than 6 millimeter, and these screws are usually not stable and need to be removed. Now, pros of robotics in spine surgery is that it enables you a very high pedicle screw placement accuracy, almost 98% compared to freehand. So there are four ways to put a pedicle screw: freehand, only using anatomy, fluoroscopic, using X-ray, using navigation, and using robotics. So robotics can allow you to put a pedicle screw with the highest accuracy. It leads to a decrease in revision and complication rates because you put a very accurate screw, and if you have the intraoperative imaging, you can control the position of the screw at the same time. And it's applicable with O-arm and with ICT. And the cons would be the cost, longer operating time, because for the intraoperative imaging and robotic time, this all leads to a longer surgery time. Robotics, as any technology, can have registration and installation issues, and there is a controversy around the learning curve, if there is any or is not, but that's a whole other subject, and we would need another hour only for that. So what does the current literature show? It shows a very high screw accuracy, even 96 to 99% across all robotic platforms. These are some recent papers which I recommend for everyone to read. They are open access, so it's accessible to everyone. Although preoperative planning allows to plan the final position of the screw, mild deviations do not seem to influence the accuracy of the fusion. And this systematic review and meta-analysis on the right side shows that what many other analyses show, that robotic-assisted minimally invasive spinal surgery is superior in terms of higher pedicle screw accuracy and reduced perioperative blood loss at the cost of higher cost of surgery. But when you look at the general complication rate and total operation time, there are usually no big differences. We've published in year 2021 our initial experience with first 70 screws and 12 cases with Circ robotic alignment module from BrainLab, and we have now entered the age of active robots for pedicle screw placement. What does an active robot mean? Well, that means that this robotic arm is placed over the projection of the entry point of the pedicle screw, which you want to implant. And this robotic arm then aligns automatically to the pre-planned screw trajectory. And then it serves as a stable instrument holder for your drill guide. So the steps in our operative workflow, and I'm going to show later an operative video to demonstrate it more clearly. We perform a preoperative imaging. On this preoperative imaging, usually CT, we implant the screws. We then perform an intraoperative imaging with automatic registration. We fuse the preoperative and intraoperative imaging. We do the review of the pre-planned screw trajectories, and then we perform the robotic assisted insertion of K-wires, and then we put the pedicle screws over the K-wires either under C-arm control or under navigation. navigation. So this is our operative setting. So the robotic arm is bed mounted. It's fixed on the metal clamp on the left side of the patient. You see here the registration, the navigation camera, the intraoperative CT. This is in the context of percutaneous stabilization of minimally invasive surgery. We do a small incision and we fix the reference area at the spinous process of the vertebra, which is adjacent to the part of the spine which is intended for instrumentation. We perform then an intraoperative scan, fuse the imaging of preoperative and intraoperative scan, and review the pre-planned screws, and then the robotic arm comes into play. So this is also one of the recent cases. You see the patient positioned in prone, robotic arm on the left side. In cases of open surgery, reference array, and in cases of percutaneous surgery, now performing the intraoperative CT, all staff leaves the OR, so the radiation exposure for the staff is zero, so staff does not get any radiation exposure, and the patient gets less radiation exposure than with the classical fluoroscopic stabilization, since we use low dose protocols and there is no need to perform a CT following surgery. So you see now the registration, the navigation camera, which looks at the registration points at the reference array and at the CT and makes a three-dimensional reconstruction, as we've explained previously. There are two ways to perform an fusion of intraoperative images, the rigid and elastic fusion, and then we take the kinematic unit of the robotic arm. This is actually the head of the robotic arm, which also has a reference array, and we place it over the entry point of the pre-planned screw. Robotic arm aligns automatically to this trajectory, and then over it we put a instrument holder, which is then securely locked, and over the instrument holder we put the drill guide, and with this small blue instrument, which is shown here with an arrow, which is called snap-on depth control, we can control how deep do we drill in the vertebra. And this would be also that what the surgeon is looking at during the surgery. You place the robotic arm over the projection of the entry point. The robotic arm aligns automatically, and this is the instrument holder, which you then see. And you can track every instrument during the surgery the whole time. This is also an intraoperative setting for percutaneous case. Once more, the robotic arm, and after we place the K-wire, we do either in fluoroscopic technique or in navigating technique. We can navigate the screw and put the screws in percutaneous technique under these towers for minimally invasive surgery. We can also put the rod. This is how it looks when we put a screw in this technique. So we first do the dilators, which dilate actually the soft tissue. And after the soft tissue is dilated, we then take a screw, which is either navigated or here in this context is under the fluoroscopic control. Note the C arm, which is also on the left side of the patient next to the robotic arm. And in that way, we have some kind of imaging control the whole time. And we see here that the pedicle screw is attached to a tower. You see the towers on the operative field, and these towers are actually enable you to place screws and to place rods without opening the muscles and without opening the without doing a big muscle trauma, and which is the whole core, the whole core of the minimally invasive spine surgery. And on the right side, this is a technique how to put a rod in the percutaneous or in minimally invasive technique. So you go with the rod under the muscle fascia into these towers, and then you can lock it safely with screws from above. So this is once more how to contour the rod and how to put the rod. These are the screws which you then put on the heads of the pedicle screws, and in that way safely lock your constructs. construct. So this is our single center experience. We've obtained a robotic arm in 2021, and these are our data until December 2024. So some 108 patients, 109 surgeries, one third of it performed in percutaneous technique for all possible indications, with a mean robotic time of 31 minutes. So robotic time would be the time which you need to place all K wires. We first put all the K wires, and then after that we put the pedicle screws. And we've placed some 688 screws, of which almost 90% were the so-called perfect A and B screws. And we also had some screw malpositions, which are mostly not due to the robotic arm, but due to the failures of navigation and failures of the navigated screw placement, or due to the very poor bone substance which some of these patients have. So when we place a pedicle screw in this technique, we have the possibility on the left upper side to control the position of the screw according to the pre-planned screw trajectory. So this blue line is the screw trajectory, which how we plan the screw, and this is the actual screw, so you can measure any deviations. And even with this technique, there is a problem of skiving, especially in percutaneous in percutaneous setting, where the screw, due to the steep slope of the entry point or due to the poor bone substance, just skives laterally from the entry point. And in this particular case, in the right lower figure, you see that the screw has been placed outside of the pedicle actually, and you can do the segmentation of this screw and of the pre-planned screw, and then repeat the implantation of the pedicle screw, and then clearly visualize where was the wrong screw and where is the right screw. These are some clinical examples due to pathological fracture, stabilization of the thoracic spine. This is the position of the instrument holder, the fusion of the images, and this is the control CT, which shows the correct position of the percutaneously placed pedicle screws. This is also a longer construct, very similar setting, and you see here the implantation of navigated screws. The blue is the pre-planned screw, the green is the actual screw, and here you see almost perfect alignment of these two plans. So what does robotic assistance allow? It allows for placement of screws with greater screw diameter and length compared with surgical navigation alone, although with similarly high accuracy. Until recently, robots were unable to decompress, decorticate, or contour or place rods, but due to advancement in AI, there are daily changes to this. There is a very good paper which came out recently, Beyond Pedicle Screw Placement, Future Minimally Invasive Application of Robotics in Spine Surgery. I recommend for everyone to read this. This is also a table from that paper. When you look at the robots, so where do we want to go? We want that robots do autonomously to do certain surgical steps with more autonomy, and there are 5 levels of robotic autonomy in spine surgery. So no autonomy, robot assistant, task autonomy, conditional autonomy, high, and full autonomy automation. We want to go to full automation for certain surgical steps. And when you look at it, all FDA-approved robotic systems currently operate at level 1. So robots at level 2 or 3 are rare, existing primarily in orthopedic surgery, urology, general surgery, gynecology, and interventional radiology. The first fully autonomous laparoscopic operation occurred in 2022 with a smart tissue autonomous robot, which performed small bowel anastomosis in a phantom and in vivo intestinal tissues with greater consistency and accuracy than both manual and robotic techniques. And there are currently several semi and full autonomous spinal robotic devices which are being created to integrate into clinical setting. There are also recent papers on minimally invasive robotic-assisted lumbar laminectomy, which is a development of a novel surgical technique. These researchers have presented a cadaver study in one case. The laminectomy planning process required 4 different drill pads, and then the robotic arm was sent to the starting point of each predefined drill trajectory. and the laminectomy was not fully robotic, but the navigated anal, burr, and caries arranger would then needed at the end of the procedure to complete it. But this is the way where this story is going to develop. There is also this amazing paper from Neurosurgical Focus for on a collaborative spinal robot system for laminectomy, a preliminary study published in 2022, with a robot which is designed to cut vertically step by step. And its safety strategy is based on force information. Very important thing is that the operator can stop the operation at any time using the emergency stop button of the robot. And there are minimally invasive robotic guided settings for facetectomy and laminectomy for transforaminal lumbar interbody fusion. Again, powered by the development of AI and of robotics in the last 2 to 3 years. Beyond placement of pedicle screws, it's possible to access Cambine's triangle and percutaneous transforaminal interbody fusion to perform iliac fixation, metastatic cancer, sacroiliacal fusions, so the increasing applications of robotics. So what would be the future in spine surgery? Well, market and training trends push medical systems towards the use of robotics. Restriction of working hours leads to less trained spine surgeons are expected to do more and more, so robotics could allow for increased safety. And currently, they act as guides to help position tools in ideal position or trajectory, for example, for accurate placement of pedicle screws. But the future generally is bright. So development of robotic suit in the OR is already happening. It will allow safer and more thorough decompressions, navigated and automated osteotomies for deformity, incorporation of AI, which will facilitate smarter operations. MRI-based navigation could enable soft tissue handling, disc work, tumor resection, and also reduction of radiation exposure, and of course, cage implantations. There are experimental settings and also some clinical work on utilization of robots for spinal tumor accession, radiofrequency ablations, osteotomies in deformity surgery, and manufacturers are actively working on creating lighter, more portable, and more affordable robots and comprehensive packages which lower the cost. And the next step is also incorporation of the Internet of Things and artificial intelligence. And the Internet of Things or Internet of Skills utilizes ultra-fast, low-latency 5G connectivity in order to allow a surgeon to operate remotely with delays of less than 10 seconds, even for distances up to 1,500 kilometers. Ideas for the futures include use of robots that are passive but provide no-fly zones around protected structures. For example, you plan the robotic laminectomy and the robot has a no-fly zone around the dura, so that's where it stopped working. There will be gloves with motion sensor, which could allow for follower robots similar to the intuitive robot that are capable of handling higher forces in spine surgery, more complex manipulations of tissue, and automatization of simple procedures such as wound closure. I'm going to talk about augmented reality a bit later. There is always this dilemma in pedicle screw placement, augmented reality versus robotic versus augmented reality plus robotics. There are also now gadgets and systems which combine the both, and this is going to be a very exciting time in front of us where all of these high-tech applications are going to be more cheaper, more available, and are going to increase the patient safety. So stereotactic brain biopsy robotics is now state of the art. So we can say that the future is now. For stereotactic brain biopsies, you have the use of the robot now almost as a guideline, almost as a must. Also for interstitial thermal therapy for stereotactic biopsies, there is a growing body of literature which demonstrates this technique for robot-assisted MRI-guided LITT of the anterior, lateral, and medial temporal lobe for temporal lobe epilepsy. In deep brain stimulation, literature shows reduction of operative time, reduction of human error, and increase of correct electrode placement. Here, one example with a ROSA robot. In neuroendovascular surgery, there is approval for cardiovascular and peripheral vascular interventions. Advantages is precise device control, elimination of tremor, radiation exposure reduction, and disadvantage would be loss of tactile feedback, which is critical for performing fine motor tasks. And this tactile feedback is actually one of the core questions of robotics, haptic feedback of the robot um, uh, and its control on the human tissue. Robotic guided skull-based surgery is used in the daily practice is still minimal, but research revolves around endoscopic endonasal approach. There is a reduction of the size of robot-assisted systems such as the Da Vinci surgical system. And there are several publications also on this robotic guided skull-based surgery. Most of these papers, which I show here, are open access. So for everybody who has profound interest in the subject, you can check it out later. There are several systems which are being tested and several clinical trials, mostly revolving around endoscopic endonasal approach. Um, in the neuroendoscopy, you would have the so-called continuum robots, continuum or snake-like robots, which include concentric tube robots and tendon-driven robots, which avoid traditional long and rigid connections in favor of flexible curving segments. This is one example of it, tendon-driven continuum robot for endoscopic surgery. In pediatric neurosurgery, it is also been used for hydrocephalus, for deep brain neurosurgery, planning trajectory, providing a stable scope holder, robotic assisted ventriculoscopy, RIV. Future direction is skull-based surgery. So the limitation would be size and angulation capacity of the robot, lack of drilling components preventing fully robotic procedures, and of course the cost. And advantages, it improves lighting and 3D visualization, replication of traditional gesture-based movements, and ability for dexterous movements ordinarily constrained by small operative corridors. So there are some cutting-edge technologies which are now available only in several centers. This is a very interesting paper, neurosurgical robot for deep and narrow spaces in the brain toward autonomous collision avoidance for robotic neurosurgery. Suggest everyone to read this. Telerobotic neurovascular interventions with magnetic manipulation. There are animal studies on use of robotic guided surgery in neuroendovascular interventions. And first robotic assisted coiling was performed in Toronto in 2019. My dear friend, Professor Baba Kateb, who is a pioneer of nanoscience and nanotechnology in neurosurgery, always talks on stem cells and nanotechnology as the actual magic leap or as the actual development in the field of neurosurgery. I could not agree more. However, there are also great possibilities to combine nanotechnology and stem cells with robotics and with AI. So nanotechnology would be a technology at nanometer scale that can be used in the real world, 1 to 100 nanometer. DNA strands, for example, measures 2 nanometer. And nanorobotics would be the design and creation of versatile robots at the molecular or cellular level, which access to all the human body, performing new procedures at the cellular level. So first challenge would be the movement. So traditional batteries are not possible at such scale, and there are options such as chemically powered engines, magnetic swimmers, electrical, thermal, and optical energy. Use would be in delivery, surgery, diagnosis, and imaging, in biopsy sampling, tissue penetration, intracellular delivery, and biofilm degradation, neural nanorobotics for cellular repair, creation of brain-to-brain and brain-to-computer interface, in particular brain cloud interface, for example, treatment for paralyzed patient. Brain-computer interface is a completely new, I mean, not completely new, but completely different and very large subject. And for that, we don't have any time. But in a broader sense, it also has a lot to do with the subject we are talking about. There are transdermally introduced robots, endoneural robots, gliabots, synaptobots. So the whole new field of microrobotics and of robotics in microneurosurgery, using operative microscopes, for example. The first operative microscope is from 1957. Due to the legacy of the late Professor Yashargil, it has become the standard in neurosurgery, but there are now new systems such as EOS 3D exoscope systems for microneurosurgery, which has a robotic guided arm, and there are pilot studies which show comparable results with improved ergonomics with exoscopes. In peripheral nerve surgery, it had also been used, for example, for brachial nerve plexus reconstruction, peripheral nerve tumors management, peripheral nerve decompression or repair, peripheral nerve harvesting, sympathetic trunk reconstructions. So the treatment is not universal. Anatomy and medical history differ from patient to patient. Adjusting movement on demand is not yet possible. This is all speaks momentarily against completely autonomous robots. And for the time being, autonomous robots are used in stereotactic assistance or equipment positioning alone. It can be addition of subroutines, wound closing, clamping, and basic manipulation. So this is one interesting paper. It's 5 years ago, where University of Washington team was working on an autonomous robot. This is conceptually called the artificially intelligent neurosurgical robotic assistant. So this is 5 years ago. So I'm sure that there are further developments of this field, and this is a step towards developing an assistant in the surgery which could autonomously assist the entire procedure. Endoscopic assisted robots, the future would be the several small robotic arms to assist two control hands to accommodate the limited forces that they can apply. For example, the surgeon would control two of these arms and the other arm would be programmed to assist the surgeon. Miniaturization of robotic tools and incorporation of curved endoscopic ports will be certainly the next big steps. And artificial intelligence and the Internet of Things in neurosurgery, we talked about this. This is actually what now power-driven the entire development, so that we have in 2 years more development than in 30 years before. Surgeon supporting robots, there is also that part of neurosurgery. We always say surgery or neurosurgery is an art and not a science, and goal is not to develop robots, but to achieve better results using robotics technology. There is A-arms, and a robot which helps surgeons to eliminate tremor and fatigue. There is an R-Helis, a surgical knee rest, which supports the surgeon's lower limb in maintaining a near standing posture. So also robots in a broader sense of that word. And this is actually one amazing development from China in the year 2021, first ever 5G remote brain surgery. The surgeon sitting in Beijing performing a surgery using 5G network. It was a deep brain stimulation electrode placement on a controlled robot on a patient which is 3,000 kilometers away from Beijing. So these distance surgeries, especially in low resource settings and in parts of the world where there are not many neurosurgeons, are also going to be very useful for our patients. This is very shortly on use of nanobots for glioblastoma resection. These are slides of Dr. Kimberly Huang from Emory University. There is a very good lecture of Dr. Huang on YouTube on use of nanobots for glioblastoma resection, and I can only recommend you to watch it. So microbots would be products which can travel to desired star point anywhere on brain surface, then proceed via nonlinear trajectory to target. And in basic pH, the minimal payload delivery, therapeutic nanoparticles, and in acidic pH or in tumor tissue, hydrogel would expand, thereby releasing nanoparticle therapeutics. Everything now in a theoretical and experimental phase or in animal studies, but developing very rapidly into hopefully very soon the clinical practice. There are clubs like here student robotics lab at Duke and at Mayo Clinic, which are working daily on automatic tumor resection. This is also going to be a part of our future. Also, Bionet Labs launched a small bionauts or small nanobots, which are tiny guided robots designed to attack brain tumors. There are further developments such as development of single port dual arms, which is reportedly steerable for endoscopes. This is all development in the last several months. Magnetically actuated tools for minimally invasive operation inside the brain, where you have a tool which will enable to perform brain surgery without cutting open the skull, powered by magnets. Um, and this is, you see also from the press and from the publications, right-sized robots could be the key to precision neurosurgery, an untethered magnetic micro robot for therapeutic delivery for neurosurgical oncology, and this latest micro robots for treating neurological diseases as intranasal, using the intranasal pathway from University of Toronto. So at the end of the part of robotics talk, there is always a question, will robots replace surgeons? When we look at some press release, robot performs surgery without help from humans, 2022, first laparoscopic surgery, and we think everything is great. And there is a saying, never bet against innovation and never bet against technology. This is all from the press of robots being everywhere in the medicine, but also never bet against the human nature. These are also some very negative press releases on the negative use of robotics. Robot-assisted surgery blamed for heart patients' death. The patient died after robot surgery. Error. Robotic surgery caused many deaths. So there are, like with every technology, there is also resistance to it, which I hope will be overcome. But on the other hand, these robots also need to be um, prone for a solid use by the surgeons, and they also have to be good and safe for the patients. So this image on the left upper side are the so-called Ludist movement. So in the 17th or 18th century, as the Industrial Revolution started, there are many jobs, many people lost their jobs due to the development of machines, something which we are witnessing today, that some of the jobs and some of the traditional occupations are being endangered due to the development of the artificial intelligence. And there was a movement of these unsatisfied workers who then went to the factories and destroys the machines, hoping that they will get their jobs back. That, of course, did not happen, and most of them ended in jail or were killed or hanged. And the same thing is with the AI. To stop the development of AI, to stop development of robotics, of all other gadgets in everyday life in medicine is not going to be important. And there is a saying that artificial intelligence and robotics are not going to replace the surgeons, but the surgeons who use artificial intelligence and robotics are going to replace the surgeons who are not using it. So, thank you for your attention on this part of my talk. I just wanted also to share since this is a neurosurgically enthusiastic women's society, some photos from our team. Upper photo is 10 years ago, some 10 years ago, a part of our team. We were always had a lot of females in our team, which was also always very good. And one of my mentors and teachers is also in one of these photos. In the lower photo is from our German Neurosurgical Congress several days ago. So you see the 10 years difference. And this is also our residents and our colleagues at one of our many parties, which we have, well, not that many, but we try to keep up the good spirit. And when I talk about my mentors, apart from my Marburg mentors, I always need to mention Professor Arnautovic, who is a big support and a big mentor and teacher of mine, whom I visited in Memphis for fellowship several times and published with him extensively. Professor Omer Hodzic from Sarajevo, and also my crew from Zenica, from my hometown in Bosnia. This is one of the lectures which I held also on robotics and on modern technologies in my hometown. And I was very, very happy that my family and that my teachers from that time, where I started my career, were there. And of course, my WFNS crew. And over this crew and my work in Africa and around the world, I've got to meet all of you guys kind of indirectly, and I'm very grateful for that. In 2026, we will be expecting a textbook on clinical applications of modern technologies in neurosurgery and spine surgery. My boss, Professor Rimsky, and myself, we are editors of that book, and we have met and gathered a lot of very good speakers for and very good authors for this book. And it is prone to be published in 2026. This is once more our department or our hospital. Some photos of the magical place called Marburg, which you are all very invited to visit. And one photo for the end from my beautiful homeland, Bosnia, with bridge in Mostar. So this would be the first part, which is dedicated to robotics. If we have time, I would also show some slides on augmented reality, and I would have one operative video. Um, as you wish, we can also answer some questions if there are any, or we can proceed. Thank you.
Thank you very much. Yes, you can share. Everyone is so much interested in your talk. It has been a very wonderful session, very interesting talk indeed, and I think everyone is much hooked. So please feel free to start your next, the next slide that you wish to share and your operative video. We will be very happy to see it.
Okay, thank you. So then we can now try to play the video. Since we talk about robotics, that would be the logical next step to show the video. This video demonstrates robotic guided percutaneous pedicle screw place. Force kit. Well, let me start something. Let me just try something. This video demonstrates robotic guided.
We can actually hear it, but we cannot see it.
Okay. So, technology problem.
Yeah.
Okay. Can you now see it?
Yes, we can now see it.
Okay.
Yes.
Okay. So this is actually our setting in OR, robotic guided percutaneous pedicle screw implantation using CERC robotic alignment module. This is a 65 years old patient with spondylodiscitis L1-2 with epidural empyema. So we performed first the robotic assisted percutaneous screw implantation and decompression, and then secondary and XLIF surgery. So this is the setting in OR. We have the patient, we have the robotic arm, the navigation camera, which looks at the robot and at the registration points on the CT. We mark the part of the spine intended for instrumentation with C-arm prior to that. And we have an AI-driven module which actually allows for automatic detection of the vertebra. So we have a CT, the software recognizes the vertebra, counts the vertebra, tells you which vertebra is which, and then you practically just mark where do you want to put screws, and the software gives you an automatic proposal of the screw placement. Now, this screw placement or this screw proposal is not always perfect, so you can always adjust it manually. You can adjust the screw length, the screw diameter, and this is the reference area, which is then being placed at the spinous process of the spine. And then when we place the reference area, we perform the intraoperative CT. We do the accuracy check on these small rubber markers, which you see on the left and the right side of the skin incision, the so-called fiducials. We talked about it at the beginning of the talk. Then we perform an accuracy check. Then we fuse the preoperative and intraoperative imaging, and we review the pre-planned screws. So for the CT, everybody leaves the OR. This is the photo from outside of the OR. And when we perform the image, we do the fusion of the intraoperative and preoperative image. So that when the patient lies prone and when he lies in the back, the spine is very flexible. So there are changes because you need to, and that's why you need to fuse. And this is the part where you put the robotic arm over the projection of the pre-planned screw trajectory. And when you are on the projection of a trajectory, the robotic arm aligns automatically to the pre-planned screw trajectory. Now, if you look here carefully, when I release the robotic arm, it makes a micro movements, and this kinematic unit aligns automatically to the pre-planned screw trajectory. Then you put a trocar, which is actually an instrument holder, and over this instrument holder, you go with the drill guide. In this way, you see the tracking of the instrument the whole time in the right upper part of the screen. And then you go with the drill guide and drill the hole in the pedicle. And then in this hole, you place the K-wire. We put first all the K-wires, and then after all K-wires are placed, we then put the pedicle screws. So this is the implantation of the pedicle screws, which I've shown earlier. This is the navigated technique. So we go with the pedicle screws inside the spine over the K-wire, and you can track the whole time the position of the pedicle screw in your navigation screen, which is visible to the surgeon. So when you are completely done with this, you perform the intraoperative CT, and in intraoperative CT, you have the immediate position control, which then reduces the need to perform a postoperative CT, and the entire radiation exposure is reduced by a factor of 2 to 3 when you compare it to the classical technique. Now, one important thing to talk about is also the total cost of the system. It goes from somewhere between 1 and 2 million euros for intraoperative imaging, for neuronavigation, for navigation setup. Robotic arm costs around 350 to 400,000 euros. But in developed countries, in solid healthcare systems, it's being reimbursed, so it actually pays off. The entire development of technology, which is being driven by the AI and by this big world race between the USA and the Far East, is going to lead that the same thing which happened with smartphones, the same thing which happened with every other technology, it is going to be one day available, hopefully everywhere. And I have the second part of the talk, which is on augmented reality. So I'm going to show that very quickly.
Please take as much time as you want. It's a single speaker webinar, and you continue on your pace, whatever you like. You can take as much time as you like because it's an interesting talk. Everyone is so much, it's everyone is really appreciating your talk. So please take as much time as you like.
Thank you very much. So I'm going to skip the introduction. This is a part of the manuscripts which were published in our department of use of microscope-based augmented reality for transsphenoidal pituitary adenoma surgery, for resection of skull-based meningiomas, for spine surgery, where we were one of the first departments in the world to describe a real case series on spine surgery supported by augmented reality, especially in intradural tumor surgery. And these are some recent papers on use of it for acoustic neuronomas resection and for use of it of resection of intradural spinal tumors. As I said previously, most of these papers are open access and they are all equipped with intraoperative videos. So there is a possibility for everyone who is listening to us to read it and to get more acquainted with the subject. So I've talked about this workflow before. Workflow which we use for robotics is the same which we use for augmented reality, preoperative imaging, and image processing. In the context of augmented reality, it is important to perform segmentation of structures of interest, vessels, nerves, vertebrae, pathways, bony structures. So everything which you want to see through a microscope overlaid on the real surgical field, you need to segment previously in the software, and then these contours are going to be transferred to your operative microscope, and then you have an overlay of the segmentations onto the real surgical field, which is far more intuitive, especially for someone who is just starting a serious microsurgical career. Registration of the patient is the key. We said previously, intraoperative automatic registration is very important if you want to have a very good augmented reality. That means the accuracy of augmented reality is directly dependent of accuracy of navigation. We perform always intraoperative registration scanning with low dose protocol, automatic patient registration, nonlinear registration of the navigation plan for spine cases, fusion of images, calibration of microscopes, and surgery. This is our operative setting where the anesthesiologist is navigation screens. They are now not anymore but ceiling mountains on the wall. Where does the surgeon stand? Nurse, navigation camera. This is one very dear paper to me on resection of meningiomas using augmented reality. Have here a short operative video to demonstrate this. We calibrate the microscope. So this is following the craniotomy. This is the view through the operative microscope. You see these segmentations are segmentations of the tumors, contours of the tumor, contour of the carotid artery and of the optic nerve. And as you progress through the surgery, you actually have in every moment of the surgery an overview where are the very important structures which are hidden beneath the tumor. And if you adjust the focus of your microscope, then you can also have an estimation which direction are these important structures and how big they are. And this allows you to feel more secure and more safe throughout the surgery. Of course, knowing the anatomy and knowing the proper microsurgery is a must. This will not replace either the anatomy knowledge or the knowledge of all the knowledge of the surgical technique, but it shortens the learning curve for a surgeon, and it gives you an additional safety and self-esteem when you know throughout the entire surgery where are you actually and where are the important structures. So this is a skull-based meningioma with which has encased the media complex and has a compression of the optic nerve on the right side. And apart from using the classical microsurgical technique for resection of this tumor, this is the visualization, this is the ICA, and you see the cross in the middle of the image. This cross is actually the focus of your microscope, and by adjusting the focus on the microscope, you can then see through in the deep of the surgical field, and in that way in every moment know where you actually are at any time of the surgery. So this is a very nice anatomy, a very nice operative video, and a very dear paper of mine. And the key is in the end. So when you see the end of the surgery and when you look at the overlays of the carotid artery and overlay of the optic nerve, then you see that these overlays are 100% despite the brain shift and despite the release of CSF. These overlays of the skull-based structures such as optic nerve and ICA are actually 100% 100% accurate. So this is one of the best videos and one of the best proofs how this technology is actually of use. You also see there the projection of the contralateral optic nerve and the AI-driven models of automatic recognition and of automatic correction of these structures are going to power the use of augmented reality in this context a lot. See here the exposure of the oculomotor nerve and of other structures of the skull base, A1 and M1, and I'm sure that there are even going to be models which will mark the structures and tell you which structure which is during the surgery of the tumors. So we've published this also on use of augmented reality in transsphenoidal pituitary adenoma surgery here in image with ICA on both sides. Very important not to injure during the transsphenoidal surgery. Reconstruction of the tumor, reconstruction of the optic nerve. This is a recent paper on resection of acoustic neurinomas using microscope-based augmented reality. Here, the segmentation of transfers and sigmoid sinus of the tumor of the 7 and 8 complex of the trigeminal nerve on the brainstem, and also this cutting edge reconstruction of the semicircular canals, which can assist you in where to drill on the where to drill in the petrous bone. And this improved visualization is actually really amazing because you can do it in 2D, in 3D. And if you have a problem with overcrowding on information and overcrowding of your screen, you can shut down all of these contours in your microscope, but you can still follow it on the big screen in the OR. And by adjusting your focus of your microscope, you can see the whole time where you are during the surgery. This is also a recent case, the pinealoblastoma, which was operated via a supracerebral infratentorial approach. These are the reconstructions of the important structures. And this is now following the decompression of the posterior fossa or following the craniotomy. You see the cross in the middle of the image. You are looking at it through your operative microscope, and you are now adjusting the focus of the microscope, going into the deep, so to say, virtually. And this is what you see on your pathway to the tumor. All the structures which you need to go through, you segment all of these structures in the preoperative image, and you see the green is the brainstem, yellow is the tumor. This is the pyramidal tract on the side, the blue arrays. And you can also, as if you have it as an app on your smartphone, you can change the orientation of these images like this. This can do somebody in the OR who is not assisting your surgery can do this on the screen, but there will be very soon gadgets, and there are some gadgets, for example, from the company Exex by Robert Mason, where you can do this by using an AR glasses or VR glasses in the surgery. You have it then as a screen, which you can use with your hand, even when you are sterile. So this will not, I have to repeat this again, this will not replace your understanding of anatomy. This will not replace your understanding of the surgical technique. But as navigation, which you use in your cars, as any technology which you use on your smartphones, this is going to help you and help your patient if you use the technology in the proper way. So what is augmented reality? Provides a real-time updated 3D virtual model of anatomical details overlaid on the real surgical field. It allows overlaying of 3D projection derived from preoperative images into binocular eyepieces of the optics of the microscope, which is then precisely aligned with the surgical field. It does not require the bayonet pointer typical of the common neuronavigation systems. So this is a very nice figure which shows, real environment, augmented reality is virtual objects overlaid in a real world environment. Then augmented virtuality, real objects projected and controlled in a virtual world, and virtual reality, which is immersion in a fully digital environment. AR for spinal surgery, there were several case reports in 2013, 18, 19. This is how we started. We've got a model, we've performed a CT of the model, then we did a segmentation of the vertebra, and then we watched at the model through the microscope, and we have seen that the segmentation is fully 100% in alignment with the segmented vertebra. This is from our recent paper on single center experience of resection of intradural spinal tumors. It's very crucial to have a good fusion, elastic and rigid. This is, for example, a case of combined meningioma and neurofibroma on the craniocervical junction. These are our intraoperative screenshots of that tumor, and you see here the segmentation of the first four vertebrae of the tumors of the pyramidal tract, or its reconstruction from the diffusion imaging in the brainstem and in the spinal cord. And this is the image which you then see through the binoculars of your microscope. You see the tumor, you see where the vertebrae are, you see where the pyramidal tract is. And for the tumors which have a very close relation to the vertebral artery, you can also see the entire course of the vertebral artery, the entire relations to the important neurovascular structures. And of course, you don't need this for a very simple tumor or for a very straightforward surgery, but our credo is that we use it also for very simple procedures, because when you know how to use the technology for a simple procedure, then you will get better around it in a complex case. So here also microscope calibration. Here is the setting of such a surgery where the navigation camera looking at the CT registration points, at the reference array, and at the microscope. This is from a recent publication of resection of herniated calcified thoracic disc. These lesions are usually best to approach from the lateral side because it reduces the manipulation of the spinal cord. You can perform a navigation accuracy check on the lateral spine, either following implantation of the implants or before. You can perform also a CT in this setting. This is in this image, for example, you see this is a herniated calcified disc. You see that the patient is lying on its right decubital position. The surgeon is standing behind the patient on his left side. So you are watching through your operative microscope the two vertebrae, and between of these two vertebrae you have the herniated disc. And this allows you and this helps you immensely to orient yourself in the surgery. You can also place an implant in this way to facilitate corpectomy, and also after you perform corpectomy, you can do segmentation of the rods, of the screws, of corpectomy and everything. This is, for example, one case of a herniated calcified disc of the thoracic spine, which was operated in an external institution. And this is what a surgeon sees when he starts the surgery. So you see where caudal and cranial is. The surgeon is behind the patient on his left side. You see the retractor arms of the XLIF retractor system, and you see through a microscope the two vertebrae, and in yellow, and the herniated calcified disc outline in blue. As you progress towards the surgery, this is now a real operative video. You know where to start the drilling. You know where the herniated disc is. There is no additional radiation for the patient, and you have the complete control of the situation. Yeah? And as you progress through the surgery, now you see more clearly the intervertebral disc space. Blue outline is the segmented herniated disc. And then finally, after drilling out the posterior third of the vertebral body, you go to the soft structures, soft tissue structures, which you then remove very carefully, not to manipulate of the spinal cord. And this is the final image. Very nice anterior or anterolateral decompression of the cervical of the spinal cord here in the thoracic spine of the dural sac actually. And we performed then an intraoperative image just to show the amount of resection. And when we fused the intraoperative image with the preoperative image and with the initial image, we have demonstrated, like here, that the herniated disc is completely removed. So intraoperative imaging is a very cool gadget because it allows you an immediate quality control. This is also a very similar case. And here you see that when you remove the herniated disc in this way, you have the expansion of the dural sac for the amount of that herniated disc, which is actually a very cool presentation of this anatomy. Several other cases, also a very similar case, lateral approaches to the spine. You can also use it for anterior approach, for example, for tailored corpectomy. Everyone who's ever done a corpectomy knows that it is not that easy and straightforward as it seems, especially in challenging anatomy, especially if you want to place a larger implant of two or three vertebrae. They need to be positioned in the midline. They need to have a very good contact with the ground and end plates, and this facilitates largely this procedure. You can also do it in a posterior surgery, for example, in the stabilization case, and this is also one surgery, intradural tumor surgery. This is just a proof of concept. Of course, for such a tumor, for such an ependymoma, you don't need actually an augmented reality. And you actually, if you are a good microneurosurgeon, like my bosses and like my teachers are, you actually don't need any technology when it comes to these kinds of surgeries. But as I said previously, we use this technology also in cases where we don't needed 100% in order to gain more practice with the technology and in order then to be able to use it for more complex cases. But also, as for the visualization of the surgical field, it helped a lot. You see here, you have the outlines of the vertebrae, and there are also outlines of the screws. So this patient underwent first laminectomy, C5 to T1, and due to the laminectomy of several levels, it also underwent the stabilization, cervicothoracic stabilization with screws, and you can perform the visualization of these screws, how they are oriented, and of the laminas in 2D and in 3D. There's also visualization of the tumor and of the dural sac and of the tumor. And this is then the microsurgical resection of the tumors, for which, of course, you don't need this technology, but it can still assist you for, especially in cases where you have a very near relation to the neurovascular structures. Now, the development of cutting edge imaging on a micro level and development of AI-driven modules and machine learning, which analyzes the surgical field and which analyzes the surgical situation and recognizes and gives automatic examples and automatic propositions of how to proceed with surgery are certainly going to help and facilitate the surgical resection so that one part of the mentoring which you previously had and you need to go somewhere and to learn a surgery is probably going to be replaced by automation, by AI, but not all of it. It will be a big help, but it will never replace the real surgical life, the microneurosurgery, and the mentoring and the process of teaching. But it has a good potential of reducing the learning curves, which we all have, and which is very long if you do not have all of these things. Yeah? So this is how the tumor then, this is how it looked in the end, the complete resection of the tumor. And this is the postoperative imaging, which shows actually a very good result. Um, Apart from intraoperative imaging, as CT and MRI, there is an increasing use of intraoperative ultrasound and a three-dimensional ultrasound, which you can then navigate. And this is a very good and very cost-effective technology, which can help you in providing a real-time image, which you can actually use from second to second. This is a patient with recurrent neurinoma at L5 vertebra on the left side who had a surgery 15 to 20 years ago, has now a progression. So this is an intraoperative image. You see, when you look at this, you just see a scar tissue. You are not very sure where to start and where to end the surgery. It's all very non-intuitive. But then if you use the intraoperative image and if you do the segmentation of these structures prior to start of the surgery, and when you look for your intraoperative for your operative microscope, then this software and the augmented reality tells you, okay, this is where the vertebra is, this is where the bone is, this is where the scar tissue begins, and this is where the tumor is. For example, here, when you look at this scar tissue, you're not very sure what is actually what, and this can help you in that. And of course, then you need to use your surgical knowledge. But I've said it over and over again. I'm saying it again. This will not help you be a better microsurgeon. But if you are keen in developing your surgical techniques, and you are working on that very hardly, this will help you to achieve your goal faster. Yeah. So this is the tumor now, and you see here the contour of the tumor. You're adjusting the focus of your microscope, and by adjusting the focus, you see the movement of these structures. And we've managed to get this tumor completely out. But what I actually wanted to show is when you use an intraoperative ultrasound like this on the left and on the right side, and you perform a three-dimensional scan, you can fuse this scan with your navigation plan. And in that way, you can then also present the vertebrae, the tumors, the whole extent of it, and that can help you a lot in your intraoperative orientation. So this is something that the surgeon sees. This is an axial view. You see the vertebra, you see the tumor, you see the tumor cyst, and if you do it in a sagittal way, you can also see the same, almost as good as in any kind of slice imaging, CT or MRI. And this is also our high resolution MRI, which shows you the tumor and the relations to the cauda equina nerves in the axial and in sagittal plane. Well, there is also an AR navigation, and this is the so-called Magic Leap glasses, which I've tried recently and which are also very nice. AR navigation provides a combination of conventional navigation system, which is integrated with the Magic Leap head-mounted device. So you are looking through your binoculars of your glasses, and you have, following the good registration, a complete reconstruction of the spine with the trajectories of the screws. You also have the visualization of the screws in your binoculars, and this is also a very big help. Current state of the art, there are these head-mounted gadgets and glasses which allow you then to see the spine as in the image on the lower side, and to enable you to put safely the screw. There is this very good paper by Professor Hertel and his team on augmented reality to improve surgical workflow in minimally invasive transforaminal lumbar interbody fusion, feasibility study with case series, placement of cages in augmented reality. And when you see the topic trends from 2012 to 2021, you see that the augmented reality in neurosurgery, that there is a number of spine papers is skyrocketing, because it is also very interesting for this emerging technology to find applications in spine. And to conclude to use good augmented reality microscope based, you need automatic registration, ideally re-registration during the procedure. It allows you immediate intraoperative quality control and objective evaluation of the intraoperative situation. AR increases comfort for the surgeon in reoperations. It's a great tool for resident education. It allows you for estimation of tumor extent even when registration accuracy is compromised. Shifting of the cord occurs when it is decompressed, and that's why the integration of intraoperative 3D ultrasound allows an update of navigation. And since we perform low dose protocols, repeated scanning is performed with reasonable radiation exposure, particularly if it is restricted to the area of interest. So thank you very much, and I hope this was somewhat interesting. And yeah, if there are any questions, I'm open to it. Thank you.
Thank you very much for your talk. It was a wonderful talk, and I think everyone really enjoyed it and really liked it. And I think there are so many compliments for you in the chat box. Most of the time, everyone really enjoyed it. It was something very futuristic, very new for everyone. So yes, great presentation, very interesting. And this was a question from somebody, Dr. Faiz Obed wants to ask. It's a great talk. My question is using exoscope and AR glasses with robotic arm will replace the microscope?
Well, that's a very good question. There are several departments and researchers who are using it, exoscopes, and some people swear on it. I was trained in a traditional school where microscope is a must, especially for deep-seated lesions, for cranial microneurosurgery, for spinal cord surgery. I don't believe that it's going to completely replace it, but I think that microscope will also probably evolve and they will be ergonomically better. They are not going to be so huge and massive, but I expect for them to be, smaller and better for use because now, for example, for posterior fossa surgery, if you do a sitting position, they are sometimes really in the way.
Thank you very much. It was an elaborate talk, I think, and thank you very much for your very elaborate answer as well. There's another question over here. It's somewhere in the chat above. I'm sorry, so I'm trying to pick it up. There also question regarding the haptic feedback. There is a lack of haptic feedback. How to compensate for this? How do you actually, compensate for the lack of haptic feedback, especially in placing screws? So there was one question on this, and there is also one question by Dr. Uday Bharti. He is asking, can we place in other trajectories of spine, that is interlaminar and in-facet fusions, etc.?
You can do any trajectory you want using robot. You can do actually, robot is just there to go along with your plan. So everything you plan, it can make. You can put a cage through the Campion's triangle, very minimally invasive. The thing is, when you look at for what are robots actually FDA or EMA in Europe approved, it's only to place pedicle screws. And everything else which we are doing is off-label. So this is something which you need to discuss with your patient always. Most of the patients don't know what off-label is, but every patient needs a right to know that you are doing something for which the instrument is actually not completely approved. But I think that the cadaver studies and in the recent time, the simulator studies, there are a lot of good models which imitate the human anatomy very good. There are a lot of good simulators, and I think that this research is something that we can need to do on a daily basis, 3D patient models of the brain or of the pathology or 3D models of the spine. If you have a 3D model of the patient's spine prior to surgery and you have a setting in which you can do the test surgery prior to the real surgery and then tell the patient, okay, we did now the test surgery on your model and tomorrow we are going the real thing. That is something which is going to be for educational purposes, I think, a real revolution in our discipline. because we have more and more neurosurgeons and orthopedic surgeons. Now, when we talk about spine, we have less and less working hours, especially in Europe, somewhat also in the United States. We have more and more patients. We need to now learn quicker things and to be better at things that it used to be 20, 40, 60 years ago. And I imagine a situation where you have a patient who is scheduled on the surgery tomorrow. You print 10 three-dimensional, very cost effective for a low price, you 10 models, you give it to residents and you give it to attending surgeons who then perform a test surgery a day prior to the real surgery. Well, not every day, because then we would only be doing test surgeries, but on certain days. And I think that is going to skyrocket the quality of the work which we are doing, because I think the whole technology, if used properly, actually leads to improved patient outcomes.
Exactly. It's like another, another like an adjunct to what we are doing today, and it can actually address several of the points, not only the application during surgery, but also learning and training, like you have very rightly mentioned. Because I have seen that in Mayo Clinic, they also use holograms of their patient, especially like cases which are complicated, like AVMs, etc. They make a hologram and just to study it and just see it how it works. And like you have very rightly mentioned, the 3D model, that it's very, very, very important, and very, it gives you some sort of a preview of what you are going to face. That's incredible. And what about, the application of robotics for like deeper corridors of the brain? It could be like, I can't, how do you see it's a complicated topic. I know it's a big topic, but how do you see the application of robotics in the deeper corridors of the brain?
Well, if you have the good navigation, if you have a high registration accuracy and good preoperative image, which you then fuse with your intraoperative plan, this is something which we are doing right now. We are placing, not myself, because that's not my field of expertise, but colleagues of mine place electrodes in context of deep brain stimulation using this navigation. And the next step is to have a robot which can place these electrodes, uh, ideally completely autonomously one day. And you have also a robotic arm, which I have shown, which is used for pedicle screw placement. You can use the exact same robotic arm for biopsies of deep brain lesions. And I've shown in my robotics part of the talk also that there are now micro robots and nano robots which are actually directed towards the deep lesions. Now, this is all at this moment science fiction when it comes to the clinical, everyday clinical practice. But when you go deeper into the field, you see that there is a lot of experimental work and also some clinical work. And I expect it in the next 5 to 10 years to come big.
That's incredible. That's really promising. But yeah, exactly, it looks very futuristic right now, but obviously it's going to have a lot of application. So I guess we mostly have a lot of compliments for your talk because it was very interesting.
Thank you.
So thank you very, very much for the time. So
Thank you.
I guess, yeah, thank you very much. It was an incredible talk, and I think we have taken a lot of time from you. So thank you very much for joining today, and I hope to have the honor of inviting you again for another talk.
Thank you. Thank you.
And thank you very much for the amazing pictures. I was so much intrigued, so much amazed to see your wonderful female colleagues. It's really nice to see all the women doing a lot of work. And I had the privilege of meeting some of the German neurosurgeons back in Dublin a couple of years ago, and they were so like very competent and very professional, which I really appreciated. And I think we need more such women because more of the women should be encouraged uh, to pursue their dreams and to be in the field. So it's an incredible field. I think we need to motivate more women because I've seen many of my students. I work with the tertiary hospital. That's why we have got a medical college, and they are like sometimes they are very much motivated, but sometimes they get a little bit discouraged when they see the environment. It gets a little bit of hectic for them, and they do not have a female role model. So it's a big thing that to have some female role models for the females to follow. So it's a huge thing, and I was so happy to see that you have shared amazing pictures, and also of your family. I have seen the women of your family are very incredible in their careers, in their fields, and they are leaders. Yes, your mother and your sister, both of them. If they are inspiring, it's amazing to see. So obviously, so I think you must be so proud of all of this incredible, walk through osteogenesis and all the things. So again, thank you very, very much for your amazing talk. It was very interesting, and I hope that everyone really liked it. And I will keep a recording of it if you like, and I keep a recording of it on YouTube. Thank you very much, so that everyone can just see it and review it.
Sure. Thank you. Thank you very much, and have a nice evening, everyone.
Thank you. Have a nice day.
Bye.
Bye. Bye. So everyone, I'm going to share the link to with you to share to download the certificate and also my book. So here is the link. So I'm sharing the link for you to download your certificate. All you have to do is to click on the link and just write your name and your email address and submit it so that the certificate of attendance will be emailed directly to you. So this is the link, and also please share your email address so that I can send you the soft copy of my book on robotic neurosurgery. I think some of you have already sent me your email address, and I can actually send you the soft copy of my book. Any questions? Anything? Have you all received the link to download your certificate? Please let me know before I wrap up the session and close the Zoom. If anyone hasn't shared your email, okay, doctor. Okay. No, no. Okay, so it's up. The link above. Can you please use it? No, no, the link. Okay, let me share. This is the link to the form. Please click on the link and write your name and your email address and just submit it, and your certificate will be directly emailed to you. Have you all received the link to the certificate? Thank you. So, okay, I think most of you have shared your email address. If you haven't, please send me your email address in the chat box so that I can actually, uh, you know, um, mm, uh, send you the soft copy of my book. So, okay, I think it's time to wrap up the session. It was so amazing to have you all. I hope you will be able to, you are going to attend the next talk by Dr. Alauddin. He's from Palestine. He will be talking about the APCs. Hello, Dr. Amr, but how are you doing today? Hi, good to see you.